Good afternoon, everyone. So we have, as often happens, a few seats up in the front, just a few. But it's so nice to see such a crowd out today. So it is my pleasure to welcome you to the first grand rounds of this semester. And to really welcome you, I'm calling up our new dean, Dean Lusniak.
Thank you. Hello, everyone. And there's a few seats here. What a great turnout for our first grand rounds of the season. To faculty and staff, you've met me before. To some of the students, this may be a first time. So first of all, I'd like to say welcome to the semester here. Right? Welcome to this incredible educational institution. And welcome to this opportunity in the midst of grand rounds to meet people who are doing incredible things out there. Shortly we'll hear sort of the CV, but I just spent a few minutes with Dr. Liu. And as we were hitting it off, right, in my office, right, kind of looking at common things, right, I spent 28 years in the federal system, he's 5 years in the federal system. So we got that Fed language, we can talk with each other. We know the code words, the acronyms. But in essence, what I want you to emphasize here is the fact that what you're being taught, what you're learning, what you're experiencing here at the School of Public Health is a mind frame. And where we really gelled in the 10-minute conversation in my office is we come from similar backgrounds. We're physicians, right? We're from the clinical world. And not everybody in that clinical world has that bigger public health perspective, that viewpoint towards populations, that viewpoint towards health and wellness. So I'm so excited that we have an esteemed speaker here today, that we have an incredible crowd here today. So use this as an opportunity to kick off your minds for this coming semester. So welcome to this, and now we'll do the official introduction. But thank you all for being here.
Thank you, Dean Lusniak. So it's my great pleasure to introduce Dr. Michael Liu. Dr. Liu is the Associate Administrator for Maternal and Child Health at the Health Resources and Services Administration, as many of you know, part of the Department of Health and Human Services. Since he arrived there in 2012, he has led the transformation of the Title V Maternal and Child Health Block Grant and Healthy Start, the expansion of maternal, infant, and early childhood home visiting program, and the launch of major national initiatives to prevent maternal, infant, and child mortality in the United States. In 2014, Dr. Liu was awarded the Hubert H. Humphrey Award for Service to America, one of the highest awards given annually to select individuals within Health and Human Services who have demonstrated a strong commitment to the health and well-being of our nation. Prior to joining HRSA, Dr. Liu was an associate professor of obstetrics, gynecology, and public health at the UCLA School of Medicine and Public Health. So he told me when I was talking with him out front that one of the things that he has missed a lot about being at HRSA is the time to meet with students. So this is an opportunity today. He has served on 2 Institute of Medicine committees, one for preterm birth and pregnancy weight guidelines. And he has also chaired the HHS Secretary's Advisory Committee on Infant Mortality. He has a bachelor's degree from Stanford, a master's from UC Berkeley, and his medical degree is from UC San Francisco. So we're happy to have him on this coast with us today. So Dr. Liu's going to talk for about 45 minutes, and then we will have time for questions and answers. When we finish that around 1:45, there will be a reception, a brief reception out in the hall. At 2:30, Dr. Liu will be meeting, so this is for my family science doctoral students and faculty colleagues. At 2:30, we will be meeting with him down in our conference room. And at 3:30, Dr. Roy's class, Man Up, is in the auditorium, and they will be meeting with Dr. Liu. And if other students want to come in, they're welcome. So you're welcome to join at 3:30 for man up. So, Dr. Liu.
Some 240 years ago, a nation was founded on the self-evident truth that we're all created equal. Now, 240 years later in that nation, that truth is still not quite so self-evident, right? You ain't created equal if you can't get the equal start. More than half a century ago, on the steps of the Lincoln Memorial, Dr. Martin Luther King Jr. told us about a dream that he had. He said that I have a dream that one day, little black boys and black girls will be able to join hands with little white boys and white girls and walk together as sisters and brothers. More than half a century later in that nation, all too many little black boys and black girls die even before they learn how to walk with their white sisters and brothers. So I really want to thank the Dean, Dr. Quinn, the Department of Family Sciences, the School of Public Health, for giving me this opportunity to come and talk with you about a problem that I think really unites all of us in this room, a problem that continues to be one of the biggest problems in public health in the 21st century, talking about the problem of racial ethnic disparities in birth outcomes. As you all know, a black baby born today in the United States is still more than twice as likely to die within the first year of life, about twice as likely to be born low birth weight, about 3 times as likely to be born very low birth weight, about 1.5 times as likely to be born preterm, and about 2.5 times as likely to be born very preterm. And although this morning I'm going to talk mostly about the black-white disparities, I don't want you to think that this is a black and white issue. It isn't. There are great disparities across different racial ethnic groups, and even within one racial ethnic group, there are great disparities. So for example, we know that infant mortality is about twice as high among Puerto Rican Americans than it is amongst Cuban Americans. There are also great differences in the causes of infant deaths in this country. So whereas birth defects are the leading cause of infant deaths amongst white Americans, causes related to low birth weight and preterm birth are the leading cause of infant deaths amongst African Americans. So the question that we want to try to address this afternoon is why? Why do you think that black babies are twice as likely to die within the first year of life, twice as likely to be born low birth weight, 3 times as likely to be born very low birth weight, and have all of these poor birth outcomes compared to white babies? Any thoughts? Any thoughts? Yes.
Access to adequate health care.
Access to adequate health care. Okay. What else?
Poverty, access to
Poverty. Okay.
Transportation.
Transportation. Okay.
The lack of resources and education.
The lack of resources and education. Okay. What else?
I think racism and stress.
Racism and stress. Okay. So certainly, over the last several decades, quite a lot of explanations been put forth to try to explain these disparities that we see. And so let's look at some of the most popular ones to see how well indeed they explain the disparities. And let's start with genetics. Okay. I'm surprised none of you talked about genetics, right? So how many of you think that these disparities are the consequences of some genetic differences between the races? All right, I agree with you. And that's certainly because if you think that these are due to some genetic differences, then you would expect that people of the same racial background really should have fairly comparable birth outcomes, and we see that's in fact not true. We know that foreign-born black women have an infant mortality that's about 1/3 lower than US-born black women, and that in fact, if you look at birth weight distribution of African-born black women, it's actually more closely related to that of US-born white women than that of US-born black women. So this would argue against a purely genetic explanation, since otherwise you expect that women of the same racial background should really have fairly comparable birth outcomes, and we see that's in fact not true. What about behavior? How many of you think that these disparities are due to differences in maternal behavior? Still nobody? Okay. Maybe. Right? And when we think of bad behaviors that lead to poor outcomes, what comes to mind? Smoking, drinking, drug use. Well, let's talk about smoking for a minute, right? So, because we certainly know that smoking is one of the major preventable risk factors for poor outcomes on a population basis. When you're talking about population attributable risks, it probably explains up to about 10% of preterm birth and up to about 25% of intrauterine growth restrictions. But what if I tell you that more white women report smoking during pregnancy than African American women? Or that African women who didn't smoke still have much higher infant mortality rate than white women who did. Right? So again, it's probably not just due to smoking or behaviors alone. All right, so you talked about access to healthcare. How many of you think that this has to do with differential access to prenatal care? Okay. Certainly a very popular explanation, right? In fact, so popular, it really has shaped our national policy over the last several decades. And we certainly know that women of color are less likely to access prenatal care early. They're also less likely to get adequate prenatal care. But if that's true, then let me actually go back. Then this is hard to explain, right? Because we do know that as a group, African Americans and Hispanic women actually have about comparable rates of prenatal care utilization, and yet the infant mortality is twice as high amongst African American women than it is amongst Hispanic women. And that even when you look at African American women who start prenatal care in the first trimester, they still have an infant mortality that's much higher than white women who start prenatal care in the first trimester, or even white women who start prenatal care after the first trimester or had no prenatal care at all. So again, it's probably not just about prenatal care. Right? Socioeconomic status. Okay. So how many of you think that this has to do with socioeconomic status? All right, good. You're picking up the pattern here, right? In research, we typically measure socioeconomic status in terms of either occupational status or household income and so forth. Right? But then again, if this is all about socioeconomic status, as a group, African American women are actually better educated than Hispanic women, and yet they have a much higher infant mortality rate than Hispanic women. Or the African American women with more than 16 years of schooling still have a higher infant mortality rate than white women with less than 9 years of schooling. Okay. Now I want you to pause and think about this for a minute. Okay. We're talking about African American women who graduated from college, who've gone on to grad schools, med schools, law school, business schools, got their MDs, JDs, MBAs. We're talking about African American doctors, nurses, business executives, and they still have a higher infant mortality rate than non-Hispanic white women who never went to high school in the first place. And virtually all of the studies that's looked at socioeconomic status compared and control for them continue to find this residual black-white difference in birth outcomes that's not explained by their socioeconomic differences. All right, I know as I was going through these risk factors that some of you were probably wondering, well, why just talk about these risk factors one at a time? Right? Because in real life, these risk factors co-occur. Why not look at all of these risk factors to see how well they explain the disparities? In fact, that study's actually been done and been confirmed by several subsequent studies. In this study that was published by Shiono and his colleagues, they went out and interviewed over 1,000 pregnant women. They asked all of these questions, including their demographic characteristics, medical risk factors, level of living, psychological risk factors, social exposures, and they even came up with a few of their own kind of newly defined indices like maternal adversity. And guess what? After they controlled for all of these different risk factors, they continue to find this residual black-white difference in birth weight that's not explained by all of these different risk factors. Okay. In fact, these 46 risk factors explain less than 10% of the variance in birth weight. Okay. So after all these decades of research, all we could explain was less than 10%. Over 90% of that just went completely unexplained. Okay. So this is about kind of the state of the science by the turn of this century, that we were kind of stuck as a field that after all of these decades of research, we weren't really able to explain the disparities very much. And this is when my colleague Neil Halfon and I, in 2003, just came up with a new way of looking at this kind of old problem. What we said was that if you think about it, what we've been trying to do for all of this time was we've been taking a snapshot of a pregnant white woman and a snapshot of a pregnant black woman, and we've been trying to explain the differences in their birth outcomes based on these snapshots during pregnancy. Of course, we're not going to explain very much, right? Because you might know how good their nutritional status is during pregnancy, but you have no idea about their preconceptional nutritional status, right? Or you might know what their prenatal care access is right now, but you have no idea about their healthcare access across the life course. So what we propose that instead of taking these snapshots during pregnancy, the way to really understand disparities in birth outcomes or other type of health disparities is by looking at their cumulative life course experiences and exposures. Okay? And that's the life course perspective that I was asked to come and talk to you all about today. And simply stated that the life course perspective is just a way of looking at life, not as disconnected stages, but as an integrated continuum. It's a conceptual framework. Some people might even call it a paradigm shift that recognizes that each stage of life is influenced by all the life stages that preceded it, and it in turn influences all the life stages that follow it. I think this is especially important for us to recognize in maternal child health, where one life stage is often disconnected from another. So for example, in perinatal health, we focus so much on these 9 months of pregnancy, we often forget that there are a great deal of life course influences on perinatal outcomes and a great deal of perinatal influences on subsequent life course outcomes. So for decades, in explaining this black-white gap in birth outcomes, we looked for those risk factors or protective factors during those 9 months of pregnancy rather than looking at the woman's cumulative life course experiences, exposures. I think that and there's a danger in that, right? It's that not only does that not explain the disparities very well, the danger is that it could actually mislead public health programs and policies. For decades, we thought if we could just get women access to good prenatal care, then we can really do something about closing this gap. Today, many of us are beginning to recognize that to expect prenatal care in less than 9 months to reverse all the cumulative disadvantages and inequities that's accumulated over the life course of women and families may be expecting too much of prenatal care. And that if we really want to do something about closing this gap, what do we have to do? We got to start taking care of women long before they get pregnant, right? Before pregnancy, between pregnancy, beyond pregnancy, and indeed across their life course. The life course perspective has two major components, an early programming component and a cumulative pathways component. So I'll briefly talk about these two components, and then we'll translate that into what we should be doing around research, practice, and policy. So the early programming model posits that experiences early in life, including those when you were just a baby inside your mother's womb, these early life experiences can actually influence your health and function for life. Okay. And this is really based on the work by David Barker and his colleagues. How many of you have heard of the Barker hypothesis? Okay. Okay. So this is really interesting and perhaps really useful in informing our work in public health. What Dr. Barker and his colleagues found through a remarkable series of studies, they actually found this association between being born low birth weight and increased risk for heart disease, hypertension, and diabetes later on in life. Now, if I were to ask you, tell me some risk factors for heart disease, what would you tell me?
Fatty food.
Okay, diet, lack of exercise, smoking, obesity, hypertension, low birth weight. How many of you have told me about low birth weight? What does being born low birth weight have anything to do with your risk for heart disease 40, 50 years later on? Well, what Barker and his colleagues hypothesized is that there are these sensitive or critical periods during development during which the function of an organ or system is being programmed. And things don't go right. If something goes wrong with that fetal programming, then that organ or system may never function optimally over the entire life course. Okay. A simple minor example is that if you were to get undernutrition in second trimester, when the pancreas and the kidneys are rapidly growing, you end up with a smaller pancreas with fewer beta cells and smaller kidneys with fewer nephrons, and that may increase your susceptibility for kidney diseases or diabetes later on in the life course. As you can imagine, the Barker hypothesis was met with a great deal of skepticism and actually some ridicule initially. But over the last couple decades, there's been this explosion of scientific evidence in really kind of an emergent field called developmental origins of health and disease that's beginning to support this whole notion of early programming. And let me just give you a couple of examples from my own area of research when I was at UCLA, starting with maternal stress. Okay. So let's say your mom was stressed out, okay, when she was pregnant with you. Well, what happened? Well, we know her brain, her body puts out a lot of stress hormones. Okay? And in a couple different ways, which I won't go into, these stress hormones can cross the placenta. So in a way, you're kind of bathing the baby in these stress hormones. You're priming the fetal brain with all of these stress hormones. Okay? What do you think that does to the fetal brain? Okay. We now know from animal studies that there are two areas of the fetal brain that are particularly susceptible to the neurotoxic effect of the stress hormone cortisol, and that's the hippocampus and the amygdala. Okay. The hippocampus is a site for learning and memory formation, and so rat pups exposed to a great deal of prenatal stress actually have a real tough time forming new memories and learning new tasks. And the amygdala is a site that mediates anxiety and fear. So again, rat pups exposed to a great deal of prenatal stress actually shows a lot of anxiety and fear during aversive situations. But more importantly, the hippocampus and the amygdala regulate the hypothalamic-pituitary-adrenal axis. This is the HPA axis that basically mediates your fight or flight response. Okay. Now, I know this diagram gets a little complicated, okay, but bear with me. I know it's kind of lunchtime, or you might be getting postprandial, but bear with me for a minute. Okay. I want you to think of the hippocampus as a brake pedal. Okay. It brakes the action of the HPA axis, your fight or flight response. Okay. I want you to think of the amygdala as an accelerator pedal. It accentuates your HPA axis. Okay. So when mom is stressed out during pregnancy, the baby is exposed to a great deal of glucocorticoids, cortisol in human, corticosterone in animals, which during critical periods of development could actually start to downregulate or decrease the number of receptors in the hippocampus, so you're making this negative feedback loop less sensitive. Okay. At the same time, it's upregulating receptors in the amygdala, so you're making this positive feedback loop more sensitive. Okay. So think about this. You're making the brake pedal less sensitive, and you're making the accelerator pedal more sensitive. What are you going to end up with? You're going to end up with the baby with a more hyperactive HPA axis with a more overactive fight or flight response. Right? And in a way, if you think about this, this actually makes a lot of sense. Because during those 9 months of pregnancy, what mom is trying to do, mom is trying to get the baby ready for the outside world. And if the outside world is stressful and hostile, what's mom going to do? She's going to try to get the baby ready for fight or flight by revving up this whole HPA axis, which in the short run can actually confer some survival advantage, but in the long run could actually have some real serious health and developmental consequences. In fact, we now have about 13 or 14 studies now that's associated, that's linked maternal stress and anxiety during pregnancy to increased risk for ADHD in childhood, suggesting that there may be something with how these stress hormones might influence the hardwiring of that fetal brain that may have some long-term health and developmental consequences. And I think what's really fascinating about all of this whole business of fetal programming is this phenomenon called epigenetics. Now, I think most of you know what epigenetics is, but basically it's volume control for genes, right? You can turn up or turn down, you can switch on or switch off your gene expression based on your environmental exposures, especially those exposures during critical periods of development. And there are several different ways to do it, but one of the most common ways is that you just simply put a chemical tag right in front of that gene. Okay? So that blocks that gene from being expressed. So in this case, this is a methyl group, 1 carbon, 3 hydrogen atoms. You put that methyl group right in front of that gene that blocks that gene from being expressed. If I were to remove that methyl group, then that gene is able to freely express itself. So generally speaking, methylation blocks, silences, turns off, turns down gene expression, whereas demethylation turns up, turns on gene expression. So we think what may be going on with prenatal stress, that it may actually control the amount of glucocorticoid receptors that gets expressed inside the fetal brain simply by methylating or demethylating the DNA. I think this is fascinating because you can now have 2 individuals with the same identical genetic codes, and they can end up with very, very different levels of stress reactivity based on what? Whether their DNAs are methylated or demethylated, which has to do with what? Whether mom was stressed out or not during pregnancy. And just to drive this point home about the importance of epigenetics, let me give you another example here. What do you see on this slide? Mice, right? You see some blonde and chubby mice and some brown and slim mice. Do you believe these mice are actually genetically identical? And in fact, all of these mice carry a gene called the agouti gene, which basically turn their fur coat blonde, the same gene also causes them to overeat, which then confer a high risk for obesity, diabetes, and cancer later on in their life course. But despite being genetically identical, researchers in the study were able to turn these mice from blonde and chubby to brown and slim simply by feeding their mothers a diet rich in folic acid during pregnancy. Folic acid? What does folic acid have to do with this? You all know about folic acid and spina bifida and birth defects, right? But what does folic acid have to do with this? So it turns out that folic acid is a very rich methyl donor. Okay? It's got a lot of methyl groups. So moms who ate a diet rich in folic acid basically methylated, silenced, turned off that obesity gene before her pup was ever born. Imagine that, someday being able to tell our patients that we know how to turn on those genes that's going to confer good health and longevity, and turn off those genes that's going to cause heart disease, cancer, and diabetes in your baby before your baby was ever born. This is no longer the story for science fiction anymore. And in fact, I think the cancer doctors are about 10 years ahead of us, right? So they're figuring out how to turn on those tumor-suppressing genes and turn off those tumor-promoting genes. Okay? Although I do have to caution you about extrapolating too much from one animal study, right? Because not all humans are rats. But this is probably one of the earliest and best examples of how that early nutrition can influence your DNA methylation, and that such epigenetic changes could actually influence your health and function, and perhaps even have intergenerational impact over the life course. A second example about prenatal programming is this whole notion of prenatal programming of childhood obesity. You all know that there's an epidemic of childhood obesity that's going on in this country. So a number of years ago, my students and I were interested in this whole idea, this whole question, whether your risk for childhood obesity could be programmed in utero. So we actually did a systematic review of the literature looking for prenatal factors that's been linked to childhood obesity. And we found at least 4, right? Too much weight gain during pregnancy, poor nutrition during pregnancy, and by poor nutrition, I don't mean just undernutrition, right? Because you can have overnutrition and still have poor nutrition. Diabetes during pregnancy, and that's both pre-gestational as well as gestational diabetes. And smoking during pregnancy. In fact, if your mom smoked during pregnancy, you have about a 2 to 3-fold increase in risk of childhood obesity, controlling for a whole bunch of different confounding factors. And we're beginning to map out the biological pathways mediating these epidemiological associations. So let's say your mom had diabetes when she was pregnant with you. What happens? Well, a lot of that glucose crosses the placenta. It causes the baby to produce a lot of insulin in response to that excess glucose. And all that excess insulin during critical periods of development basically does 3 things. 1, it lays down a lot of fat cells. 2, it causes a programmed insulin resistance. And 3, it causes a programmed leptin resistance. Okay? Now, you all know about insulin resistance, but what does leptin resistance do? What's leptin? It's basically a satiety hormone, right? It tells you to stop eating when you're full. So if you get leptin resistance in the brain, what are you going to do? You're going to keep on eating. Right? Leptin also tells your pancreas to stop producing insulin. So if you get leptin resistance in the pancreas, you're going to keep on producing insulin, which is going to lay down more fat. Okay? So by the time that baby's born, she's already born predisposed to a lifelong struggle with overweight and obesity and early onset type 2 diabetes because of all of these excess fat cells and programmed insulin resistance and programmed leptin resistance. And then you add on top of that a fast food nation that supersizes everything, and that may be partly what's driving this whole epidemic of childhood obesity and early onset type 2 diabetes that we see in our nation. So if we want to prevent childhood obesity in America, what do we have to do? It's probably not enough just talk about school lunches and physical activities, right? You got to start much earlier than that. Okay? You got to make sure that mom gain an appropriate amount of weight during pregnancy, that she gets good nutrition, right? That her diabetes is in good control, and that she quits smoking, or better yet, don't take up smoking in the first place. The second component of the life course perspective has to do with this whole notion of cumulative pathways. Okay? And basically what the cumulative pathway model says is that chronic stress, I'm talking both in terms of physical stress as well as psychological stress. Chronic stress can cause wear and tear to your body's adaptive system, which can lead to a decline in your health and function over time. Well, and let me give you another example from the stress literature. This time, your mom didn't have to be stressed out when she was pregnant with you, but rather it's that chronic stress and strain, that daily wear and tear that a lot of women, and especially women of color, go through that cause this dysregulation in their body's adaptive system. Well, how does that work? What happens to your body when you see a saber-toothed tiger? You run, right? And what makes you run faster is your body actually activate the HPA axis and sympathoadrenal medullary system. You're putting out all of these stress hormones to help you run away from the tiger. Okay. Now, what happens after you got away? Right? Your blood pressure comes down, your pulse comes down, and you relax. Okay. And that's the amazing thing about the human body, is that it knows how to shut itself off once the stressor has been removed. And that's what we call allostasis, okay, which means to maintain stability through change. Maintain stability through change. Okay. It's a concept that's very much similar to homeostasis that I think most of you are familiar with. But whereas homeostasis really talks about the body's ability to maintain equilibrium within a very narrow range of biological variability, right? Like maintaining your body's potassium level. Allostasis is really a more dynamic concept that talks about adaptation to environmental change. And allostasis works very much like very much by a negative feedback mechanism that's common to many biological systems. Okay? It works very much like a thermostat. Okay? So let's say that the temperature in this room falls below a preset point. What happens? Okay? The thermostat kicks in the heat, right? But as soon as that preset point is reached, the heat turns off the thermostat to prevent this room from being overheated. Well, it turns out that the same thing actually goes on inside your body. So when you're under stress, your body kicks in the HPA axis to produce cortisol. Cortisol, in turn, feeds back negatively onto your brain, okay, to shut off your HPA axis to keep your stress response in check. So that's allostasis at work, maintaining stability through change. So allostasis works well for stress you can either fight off or run away from. Okay? But what happens if there's nowhere to run? What happens if you can't get away? You get eaten, right? But if you don't get eaten, what happens? Okay? So in the face of chronic and repeated stress, your body loses that ability for self-regulation, so now you can turn it on, but you can't shut it off. And what we find in animals and humans who are subjected to chronic and repeated stress, that they actually walk around with higher circulating levels of stress hormones. Okay? And if you were to subject them to some natural or experimental stressors, that they would put out a lot more stress hormones than people naturally would. And that's when you go from being stressed to being stressed out. Okay? And there's actually a big difference here. There really is a difference between protection and damage. Okay? So when you're under acute stress, your body kicks in the sympathetic response, okay, to increase your cardiac output, the amount of blood that's being pumped out by your heart every minute, okay, that to help you run away from the tiger. Okay? But when you're stressed out, you can't shut off that sympathetic response, and that chronic, uncontrolled sympathetic activation over time can lead to hypertension and cardiovascular diseases. Under acute stress, your body actually kicks in the HPA axis to produce cortisol. And cortisol is a glucocorticoid, and one of the main functions of glucocorticoid is it actually converts your body's stored energy into glucose, which then becomes readily available fuel again, to help you run away from the tiger. Okay? And it does that partly by impeding insulin action. Okay? But under chronic stress, you can't shut off the HPA axis, and all that excess glucocorticoid over time can lead to glucose intolerance and insulin resistance. So most of you know, under acute stress, your body's immune system actually works better, but under chronic stress, you become a lot more susceptible to infection and inflammation. And the way to think about this relationship, okay, is to think of the HPA axis as a set of brakes on your body's immune system. Okay? So if you're chronically stressed out, that's like driving with your foot on brakes, right? What happens to the car when you drive like that? Oh, we all hate to drive behind people who drive like that, right? The car just doesn't run very well, as in the case of depressed immune function and increased risk for infections, even something as innocuous as bacterial vaginosis, which then could increase your risk for preterm birth. Okay? But what happens if you keep driving with your foot on the brakes over time? And wear out those brakes, right? And now you have a much bigger problem. You can't stop the car, as in runaway inflammation. And think of all the chronic diseases in our society today that's characterized by excess runaway inflammation. Name some of them. Hypertension, diabetes, heart disease.
Chronic pain.
And think about all the diseases that are characterized by a great deal of racial disparities. Right? Lupus, nephritis, all the autoimmune diseases. And do you think chronic stress might actually play a role in the pathogenesis of chronic diseases and in the origin of health disparities in our society today? Under acute stress, you actually get growth of neurons inside your brain, especially in these learning centers in the brain. It's almost designed to help us learn from our mistakes. And that's why I bet most of you still remember vividly exactly what you were doing when you heard about 9/11. Okay. And some of you could probably still remember exactly what you were doing when you heard that JFK was shot or Dr. King was shot, right? Even though you can't remember what you had for dinner last night. So under acute stress, you get these the growth of neurons inside your brain. But under chronic stress, the exact opposite happens. So rather than growth, you get atrophy and death of these neurons. And that's why women who are under chronic stress begin to report that they're becoming more forgetful, that they're losing their memory. Then Bruce McEwen at Rochester University provides perhaps the best illustration of these concepts of allostasis and allostatic load in this cartoon here. Okay? And this bottom image here, right? This is a picture of allostasis. Two kids balancing on a seesaw, maintaining stability through change. Okay. What if I were to replace these two 5-kilogram kids with these two 500-kilogram sumo wrestlers? Okay. You put so much stress and strain on that seesaw that sooner or later, that seesaw's going to break. Okay. And what if a woman were to enter pregnancy carrying these two 500-kilogram sumo wrestlers on her back? It's not going to have a very good pregnancy. So I had served on an Institute of Medicine committee on understanding prematurity. Now it's called the National Academy of Medicine. And during committee meetings, we actually had quite a bit of discussion about the need to rethink the causes and prevention of preterm birth in this country. And we know that this is important because preterm birth is one of the leading causes of infant mortality in this country. Okay. And it's also the leading cause of racial ethnic disparities in infant mortality in this country. That I mentioned earlier that in African-American baby born today is about 1.5 times as likely to be born preterm, about 2.5 times as likely to be born very preterm, and that 2.5-fold difference in very preterm birth accounts for about 2/3 of all excess black infant deaths in this country. So if we could really do something about preterm birth, then we could really do something about closing that disgraceful gap in infant mortality. During committee meetings, we had a lot of discussion about the need to rethink the causes and prevention of preterm birth, and that's because we used to think that preterm birth was the consequences of some precipitating event, like a stressful life event or infection that occurred right before the onset of labor. But we now think that maybe the origin of preterm birth may occur much earlier than that, and that your vulnerability to preterm delivery may be traced not only to exposure to stress and infection during pregnancy, but to your host response to stress infection, and that's the stress reactivity and inflammatory dysregulation that's been patterned over the life course by these early programming and cumulative allostatic load mechanisms that I've been talking about. So if we want to prevent preterm birth in this country, what do we have to do? It's a very simple message here, right? We've got to start taking care of women before they get pregnant. And a very important objective of preconception care has to be to optimize women's health and restore allostasis before they get pregnant. Now, just in case you think I'm just talking about the baby, I'm not. Okay? Because that same allostatic load, okay, that same stress reactivity and inflammatory dysregulation that wreak havoc during pregnancy will go on to wreak havoc in mom's blood vessels and vital organs over the next 15, 20 years to cause chronic diseases. Okay? So we're beginning to get studies like these that are beginning to show that the studies show that women who had a preterm birth were significantly more likely to either get hospitalized or die from a heart attack within the next 15, 20 years compared to women who never had a preterm birth. And studies like these are beginning to reframe the whole issue of preterm birth from simply a children's health issue to a women's health issue. That preterm birth may be a sign of things to come. It may herald the development of chronic diseases later on in life. All right, so that's the life course theory. Right? So how do we translate that into research, practice, and policy? So I'm just going to get this discussion started. A few years ago, my colleagues and I from across the country proposed a 12-point plan to close this black-white gap in birth outcomes. Now, the reason we did this is obviously not because we have all the answers, but just to reframe, to stimulate a different discussion about what we need to do to address health disparities in this country. Okay? I'm not going to go over all 12 points, but the first 4 points around interconception care, preconception care, quality of prenatal care, and expanding healthcare access over the life course move us beyond our current focus on prenatal care to addressing the health needs of women and families across their life course. The next 4 points around strengthening father involvement, enhancing systems integration, creating reproductive social capital, and investing in community building, yet move us beyond our current focus on trying to change individual behaviors to talking about strengthening families and communities. And the last 4 points about closing the education gap, reducing poverty, supporting working mothers and families, and undoing racism, okay, move us beyond our current focus on this biomedical model to start to address some of those social and economic factors that underlie much of the health disparities that we see. Okay. Again, I won't go over all 12 points right now, but I just want to pick up this last point around racism. Okay. And we certainly have a growing body of evidence linking racism to poor birth outcomes. In this study by my friend Jimmy Collins and his colleagues, they found that women who were exposed to interpersonal racism in 3 or more domains over the life course were almost 3 times as likely to have a very low birth weight baby. And that's just interpersonal racism, right? What about institutionalized racism? Okay. So Dr. Kamara Jones, who was the president of APHA, talked about these 3 different levels of racism: internalized, interpersonal, and institutionalized. Okay. Internalized racism is when the racism is so pervasive that women of color come to see themselves as inferior. Interpersonal racism is kind of racism that we think about when we think about racism, about prejudices and biases. Okay. It's about like being followed around when you're shopping at Nordstrom if you're a person of color. And I think the best example of this is my medical school roommate, who's an African-American man who, upon graduation from UCSF, was awarded the Golden Cane Award. This is kind of voted by the entire graduating class, right? To that one individual who exemplified everything we all wanted to be in becoming a doctor. So that was my roommate. Okay? And yet he said that when he's driving around in a nice neighborhood, he got stopped frequently. And you don't even have to like measure his cortisol levels and stuff. You can just see the vessels popping out, and he just gets so mad when he talked about those experiences. And then there's another level of racism that's perhaps even pernicious and pervasive, and that's institutionalized racism, which is defined as differential access to goods and services that a society has to offer based on your race, based on the color of your skin. And Dr. Jones used this tale, this allegory called the gardener's tale that many of you may have heard about, to illustrate these 3 different levels of racism. She said that in this flower garden, there are 2 flower pots. Okay? In the flower pot with poor and rocky soil, the gardener planted seeds for pink flowers. Okay? And in the flower pot with rich and fertile soil, the gardener planted seeds for red flowers. Okay. So guess which flowers grew better? Right, the red flowers. Right? In time, these flowers passed seeds into the same soil, so generation after generation, the red flowers flourished while the pink flowers just languished, kind of struggling to survive. Okay. So how do you get things right in that garden? How do you get things right in that garden? Well, Dr. Jones said that it's probably not enough to just sit down with the pink flowers and tell them that pink is beautiful, right? And it's probably not enough to just sit down with the gardener to do some cultural sensitivity, cultural competency training, right? How do you get things right in that garden? Two ways, right? You either mix the soil, or you enrich the soil in the pink flower pot until it is as rich and as fertile as the soil in the red flower pot. And that's really what we're talking about, right? We're talking about enriching the soil with good education and good housing and good health care and good opportunities, creating those conditions that all kids and families can succeed and thrive in our nation. So I started this presentation by talking about a dream that Dr. King had about half a century ago. So let me now close with a dream that I still believe in. And it really is a dream that I didn't just read in a textbook or learn in the classroom. I saw it and lived it, perhaps like many of you. I was born to 2 immigrant parents without a college education. In fact, my mom, she actually never graduated from high school or even middle school. See, my mom was only 11 when her father died. So as the oldest daughter in the family, she had to drop out of 5th grade to go work in a factory to help support the family. So the first home that I was born into, on the other side of the tracks in Taipei, where a family of 6 was crammed into, no flush toilet, no running water, and health insurance. We didn't have health insurance. There wasn't such thing as health insurance back then. And so when you get sick, and unfortunately I was actually sick a lot as a child, you never knew how much the doctor or the medicine was going to cost. Okay? And so my parents actually had to make those decisions that you hear about, right? Paying for food or paying for medicine. And at one point, my mom actually had to sell her wedding ring to pay for my medicine. So I didn't come from an educated family or a wealthy family. But none of that mattered anymore once we got to this country. And none of that mattered because of a dream. It didn't matter because the American dream says that you don't have to be rich to go to the best schools. Okay? It didn't matter because the American dream says that everyone gets a fair shot, no matter where you're from, or the family you were born into, or the color of your skin. It didn't matter because the American dream says that if I just work hard enough and try hard enough, I could give my children a better life, the kind of life that my mom wouldn't even ever dare dream of. And my two little girls, okay, that's Sasha. Actually, they're not little anymore. So Sasha is now 14, Avery's 11. So by this fall, I'll have a high schooler and a middle schooler. So my 2 girls, the granddaughters of a girl who had to drop out of 5th grade to go work in a factory, can now grow up in a nation where they get to be anything they want to be. That's a true testament to the endurance strength of the American dream. The question is, if my girls can get that chance, why shouldn't every child in America get the same chance? If my girls can get a fair shot, why shouldn't every child get a fair shot? So this is really what we're fighting for, right? This is the gap that we're trying to close. It's not just a gap about infant mortality, but it's a gap about what our nation is, and perhaps has always been, and what we can be, what we must be. The Maternal and Child Health Bureau has been fighting this fight for over 100 years, dating back to the establishment of the Children's Bureau in 1912. I'm proud and humbled to be leading the Bureau in this fight now. I ask you all to join me. If you still believe in America's greatness, if you still believe that every child deserves a fair shot, please join me, and together, let's fight to close these gaps, and let's fight to make sure that we give every child, every family a fair shot at reaching their fullest potential, because ultimately that's what the life course perspective is all about. Thank you very much. Okay. So I guess we have about 15 minutes for questions, comments, dreams, aspirations, anything that you want to share with the group? Yes.
Just a question. I'm not sure how much you know about this, but how, in doing that and trying to reach that goal to give everyone like a fair chance, do we not start to form some form of socialism? You know, with the sharing of money, the passing down of money, because it'll be hard. I mean, like, where is the funding coming from to even out the scales, if you will, across the board, as far as medicine, education, all those things? Because, like, my dad and I have this conversation, and I feel like to change this is like a ripple effect if it starts with education. So if you put the funding in education, then the rest will follow suit. But the way that it seems like you're talking about it, you want to, like, kind of do all at one time, and I just want to know, like, how could we fund that, if you even know?
And I don't know if you all share this question. I guess the crux of the question is how this does not argue for socialism, right? And obviously that's a much bigger conversation than we have time for here today, and we can compare and contrast the strengths and limitations of different forms of economic systems. But I still truly believe that you can achieve these goals within a capitalistic system. And we've done it, I think over time we've seen how how progress is made. It may be slow, it may be bumpy, but I do truly believe that there are things that we can do to achieve health equity for all without a major transformation of our economic system.
Thank you, Dr. Liu. Edmund Shanasa, MCH program. More of a comment than a question. They said the revolution has to come from within, and in this case, the revolution would be a source of information, I think, just to make the link between our social structure and health clearer, as we're doing here and getting the information out. Just wanted to reiterate what you just said, Dr. Liu, that this can be done within our system.
Thank you.
Thank you.
Thank you, and I appreciate that comment, and certainly that also kind of reminds me of this model that we use quite often in public health, the Richmond College Check model that some of you may be familiar with. Julius Richmond was the founder of Head Start, and Mel Kolichek was the originator of the Kolichek Index for prenatal care utilization. But basically, they came up with this model that says that if you want to bring about real social change, you need three things. Right? You need the knowledge base, you need social strategies, and then you need political will. Right? Political will. Okay? So I think we've certainly made a lot of progress in terms of expanding our knowledge base, in terms of coming up with evidence-based strategies. But I think what often is missing from these types of discussion is how do we generate that political will to do something about this. Yeah, I think we're great enough of a country to get this done. The question is how do we generate that political will to actually get it done.
You start off the presentation discussing, obviously, U.S. national data. Are there examples globally, right, of similar trends or, more importantly, of success stories where this divide has been dealt with?
Yeah, so that's a great question, and certainly there's been a number of studies kind of doing that type of international comparisons and seeing what strategies other countries have employed to not only improve their birth outcomes, but actually to reduce the gap in birth outcomes. I think the studies are stronger when you start to look at overall improvement, and we've seen some of the Scandinavian countries, some of the European countries that really have made progress, really have invested in improving the social conditions that women and families live. And so we do know that some of those strategies, some of the social conditions that we talked about does make a difference. What the studies haven't been as clear as strategies to close the gap, and whether it's racial ethnic gap, whether it's socioeconomic gaps. I do think that again it ties back to some of the socioeconomic strategies, kind of the larger policy questions that rather than improving access to prenatal care. And again, this is not to discount prenatal care. I think prenatal care is certainly very necessary. It's just not sufficient to close the gaps. So I think that we're still trying to figure out what works best. One of the things that we have done over the last few years at the Bureau is to support this collaborative improvement and innovation network across. We'll start with the 13 southern states. Now it's in all the states around the country, and the idea is that rather than keep reinventing the wheel, rather than trying to figure out the solution in a silo, can we can bring the whole science of quality improvement and collaborative innovation, and to really help support the states in terms of figuring out what are the strategies that will work to reduce the disparities. We've seen some promising results early on, but certainly a lot of work still needs to be done.
So just a personal experience, many years ago, my cousin who was mixed, her boyfriend murdered her son while she was pregnant. And her child has had massive issues her entire life, and I've always wondered if it was because of the stress that she held during that time period. And so that enables that concept.
Yeah, and this is certainly where I think that's where the growing science is, not just in pregnancy, but also in early childhood. And this is why you have Nobel laureate economists that talks about if we really want to do something about improving population health, that we really have to invest early in terms of supporting healthy early brain development. And again, not just in areas that help cognition and language and reasoning, but also in areas that deals with impulse control, self-regulation, as well as areas of the brain that help you connect to other people, to relate to other people, which are so important for success in school and later on in life. In fact, a couple years ago, I had this opportunity to attend a global conference on early childhood development that was hosted by the Vice Premier of China that brought together health ministers, education ministers from around 30 different countries, and all of these countries get it. Okay, they understand that to stay globally competitive in the 21st century, we really got to invest early, and we really got to invest in maternal child health. And in fact, China has actually made investing in early childhood, that early investment, as its key national strategy for securing its economic competitiveness in the future and lifting millions of families out of poverty. And so certainly I think that's driven by this growing science that we have just in terms of what we need to do as a nation if we want to stay globally competitive in the 21st century. Other questions, comments?
Thank you very much for your talk. One problem with doing life course analysis is that the data can often be hard. So speaking from a person's perspective, can you talk about initiatives that you're thinking about that can help us link data from early life and follow people over the life course?
Yeah, no, I think that the whole life course perspective opens up a whole kind of new paradigm for research. It is in terms of strengthening our ability to link data, both across domains and as well as kind of cross time. And right now, we can't even link data from prenatal records to intrapartum to postpartum, let alone from one birth to the next birth or one generation to the next generation. So certainly, there has to be a lot more work that's done in terms of supporting the data linkage across domains and across time. It also calls for I think better study design, longitudinal study design in terms of being able to follow kids and families over time. When I was at UCLA, I was a lead investigator there for the National Children's Study, which I think had the right idea in terms of following a cohort of kids and looking at all of these different environmental exposures, including not just exposure to not just the physical environment, but social environment and how that impacts on health development over time. As you know, it was a ill-fated study. But I think some of the hypotheses, some of the questions that were raised in terms of taking the life course perspective on how do we do better in terms of supporting healthy development over the life course, I think those questions remain, and certainly I think that will be continues to be priorities for research agenda. And most importantly, I do want to get us out of the discovery phase to doing more intervention studies, right? Because we do over the last 20 years have this kind of growing epidemiological data supporting life course theory, but what we're really kind of missing is how do you translate that into practice? And so there are a lot of key design issues about how you design a study like this, whether it's single intervention versus a bundle of interventions, whether it's single level versus multi-level, and how, and when are the sensitive or critical periods by which you want to intervene for what outcome. And so as a field, we can't get stuck in the discovery phase. Now, that discovery phase certainly has its place, but I think it's really time for us to think about how do we design these intervention studies that fully support the life course health development of children and families across their life course.
Well, I think your comment you just made raises the issue of thinking about these challenges. There's such a systemic perspective that we need to be considering, and the complexities of trying to think about this from a systemic perspective. As you said, it's not one factor you started with, for us conceptually to even think about it, but then think about how are we going to study that, and then create interventions that are emblematic of that.
Just a brief comment. I think one of the problems that you raise is really a critical problem. How do you plan these unique kind of studies that someone would actually fund? But there's a growing number of people who believe that we ought to start from the other end. And the saying that they like to use is, if we want more evidence-based practice, we need more practice-based evidence.
Mm-hmm. And just for folks in the audience here, you want to talk a little, because I think that's actually a really important point here. Okay. Do you want to talk more about that?
No. This is your dance.
Well, let me give it a try. Okay, so basically, and this is something that we have been trying to figure out, and one of the latest things that we've done in terms of redesigning one of our kind of research network is how do you create that loop kind of feedback system so that practice is informing research, and then research is informing practice, and we don't do that very well right now, and so that's where as we think about some of these sort of interventions that's been done. For example, I think I'll digress for just a couple minutes, because this is certainly something that we're trying to figure out how to do and how to support in our bureau. Traditionally, many of these sort of life course interventions that's been developed have been based on these painstaking, long-term, randomized controlled studies. We've seen that with preschool. We've seen that with home visiting and nurse-family partnership and so forth. And the way you do that is, once you define the intervention, you really can't change it, right? And then you randomize kids and families to the intervention group or the control group, and then you try to assess the effectiveness of your intervention by looking at which groups had better outcomes. And if the intervention group had outcome that's statistically higher than in the control group, then you declare success, and then you spread and scale to a national program, and then you wonder why in the national program you don't see the kind of robust effectiveness that you often see in these intervention studies. And the problem is that what you're doing is you're basically taking an average effect of your intervention across the entire study population, without being able to talk about whether that this intervention works better for some groups and this intervention actually doesn't work for other subgroups within within the population, and so this whole one-size-fits-all intervention just doesn't work very well at all. So as folks are starting to talk about precision medicine, right? The right drug for the right person at the right dose. In public health, we start talking about what would precision public health look like, right? So the right intervention for the right population under the right circumstances. And how do you actually design an intervention study that, and certainly there's still place for well-designed randomized controlled trials, but how do you design an intervention study and a research platform that's nimble enough to allow you to continuously adapt and improve your strategies that are targeting and tailored toward the specific needs of the population that we're serving? If you have answers to those questions, I would really appreciate it, because we're really trying to figure out how do we do better public health research in the 21st century.
So first, let me join me in thanking Dr. Liu.